and it's going to be dedicated to eosinophil gastrointestinal diseases. Next slide, please. During this webinar, we're going to be covering 3 topics, and this webinar has been sponsored by Alicos. This is actually our first sponsored webinar this year. Next slide. This slide just shows you an overview of the presentations we will be seeing today. And as you can see, we'll be discussing not only eosinophils, but also mast cells and involvement of CD4 positive T cells in eosinophilic gastrointestinal disorders with a special focus on eosinophilic esophagitis. Next slide. I just thought it would be nice to show an overview of the different topics that have been shown this year, that have been presented this year in the setting of our webinar series. And as you can see, the eosinophil has really been at the center of all of these different sessions. We discussed the role of eosinophils in COVID, in cancer, in parasitic disease, in metabolic health and disease, as well as a series of more translational topics in terms of eosinophil research in airways, regulatory eosinophils, interactions with non-immune cells, where we heard talks about fibroblasts, nerves, and TSLP, and eosinophil mediators in disease. Next slide, please. With these webinars, we have been continuing to fulfill one of the main missions of our society, which is being able to foster education, but also exchange around our favorite cell, the eosinophil, and discuss both diseases and research on these cells in order to further understanding. If you desire to join our society or have more information on what we do, the website is shown in the lower left-hand corner of the slide. Next slide. Just a few technical points before handing over to the chair, to the moderator. You have a question and answer button if you want to ask questions during the session. You will not be able to ask questions verbally. These questions will be addressed to the different speakers by today's moderator. All attendees are muted and the chat feature is disabled, so you really only have access to the question and answer button. If you have any technical difficulties, well, as usual, usually what works the best is trying to log off and logging back on again. And also, please be aware that the webinar is being recorded. So if you have missed something, or if you'd like to share a presentation afterwards with someone you know, this recording will be posted on our website shortly after the presentation. Next slide. So I'm very, very grateful to today's moderator, Kathy Peterson, who's professor of medicine at the University of Utah and who works in the Division of Gastroenterology. And as such, she's extremely well positioned to moderate today's session.
Thank you so much. I want to thank the International Eosinophil Society for allowing me to moderate a session near and dear to my heart. I'm exceedingly happy to introduce our first speaker, Dr. Josh Wechsler. He is an attending physician in the Division of Gastroenterology and Hepatology and Nutrition and assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. And he is going to talk today on rapid activation of mucosal mast cells drives epithelial barrier dysfunction in eosinophilic esophagitis. Josh, to you.
Okay, right now I think I am unable to share. Oh, here we go. Well, thank you very much, everybody, for the warm welcome. Particularly just wanted to say thank you to Dr. Rufos, Dr. Mark Rothenberg, Dr. Bruce Bachner for the invite, Dr. Kathy Peterson for moderating today's exciting session. My talk today is entitled Rapid Activation of Mucosal Mast Cells Drives Epithelial Barrier Dysfunction in Eosinophilic Esophagitis. Here's my disclosures. So my objectives for today are to discuss some background on mast cells and the relevance to eosinophilic esophagitis, to discuss the importance of epithelial barrier dysfunction in eosinophilic esophagitis, provide evidence of rapid mast cell activation and a potential role for mast cell activation in driving epithelial barrier dysfunction. Well, mast cells are a tissue-resident granulocytic immune cell that requires special stains to visualize. And I really always like to raise this point because they go unnoticed in many, many, many diseases. On the left, you can see a stain for tryptase, a ubiquitous protease expressed by most mast cells. And in fact, a protease that is often found free in the tissue as it's released by mast cells. And on the right, a stain for KIT or CD117, which really stains the entire mast cells. It's not something that's released. So these special stains are really required to visualize these cells. And on the left, you can see a patient that has lots of them, of course. And many chronic allergic diseases like EOE, like asthma, like chronic rhinosinusitis have increased tissue mast cell density. You can see here work from over 10 years ago, looking at mast cell counts in the esophagus as being quite elevated compared to controls. Some additional work looking at asthma patients, and as well some work by Takabayashi et al. From Northwestern looking at patients with CRS with nasal polyps. And even non-allergic diseases as well can have high mast cells. On the right, you see a study looking at patients with both ED, inflammatory bowel disease, as well as irritable bowel syndrome, a non-inflammatory disease. And really in that study, they found no differences between the patients with ulcerative colitis and IBS-D in terms of the relative number of patients that seem to have high numbers of mast cells. So it's not always just in the setting of inflammation as well. And even recently this year, we learned about how IBS patients have activatable mast cells found in their colon. Well, mast cell density is variably decreased with treatment in response to the removal of food antigen. In fact, this is work by our moderator looking at the elemental diet in eosinophilic esophagitis. And what they found in their study, in which they treated patients with formula containing no intact protein, only amino acids, is that mast cells generally are decreased to a variable degree. You can see some patients don't really have much of a drop in mast cell counts. And similarly, we've looked at a cohort of children treated with milk elimination. You can see in the patients that had low eosinophils after treatment, they all seem to have a significant drop in their mast cells. And that's compared to the patients that don't have a significant drop in their eosinophils, in which there still are persistently elevated mast cells. But I think you can appreciate that even among the patients that are responding to mast cells, there's quite a wide range of the density of mast cells after treatment. And we think of 15 eosinophils per high-powered field in the millimeters squared. You multiply that by 4 and you can figure out quite quickly that 60 eosinophils per millimeter squared would be something that would be considered pathologic if it's above that. And certainly we have a number of mast cells sitting in patients that have responded to therapy that fit with that. Well, mast cells contribute to many diseases via 2 forms of activation by a variety of stimuli. One, they can degranulate, and with degranulation, they rapidly release preformed mediators. 2 is they can release synthesized mediators. These include lipid mediators, prostaglandins, leukotrienes, as well as cytokines and chemokines. And in doing so, they can contribute potentially to a large number of diseases. They're well known to contribute to food allergy via the IgE receptor, but they can also contribute to other diseases via non-classical receptors like MRGPRX2, which is responsive to things like substance P, or other receptors like TLRs as well that can contribute to a variety of other diseases and have been implicated in diseases like ulcerative colitis, including my own work. Well, preformed predaces are released during rapid activation, are stored in granules and define the mast cell subtype, which varies by organ and tissue compartment. Here you can see a study on EOE patients looking at 3 major proteases: carboxypeptidase A3, tryptase, which is ubiquitous, as well as chymase. And chymase and CPA3 are fairly restricted in mast cells, whereas tryptase is ubiquitous. And in the esophagus, you tend to find mast cells that are very high in both tryptase and carboxypeptidase A3, but relatively low in chymase. And all 3 of these markers are reduced with treatment. And from organ to organ, you find different degrees of mast cells that contain these collections of proteases. So the lung, for instance, has a very high number of mast cells only containing tryptase, whereas in the skin, it's much more balanced between the tryptase containing mast cells and those with tryptase and chymase. Activation via degranulation of mast cells is increased in allergic and inflammatory diseases. This has been shown for a number of diseases. So this is very interesting work looking at a mast cell activation test as a diagnostic for food allergy. And in fact, when you take the serum of food allergy patients, you can activate mast cells that have been exposed to anti-IgE and cause them to degranulate. And this leaves CD63 on the surface of the mast cell, and you can detect it. And this has a very high sensitivity and specificity, leading to a very good area under the curve for diagnosis of food allergy. So we can detect mast cell activation and we can actually leverage it as well. In addition, that's been similarly seen for asthma, and this is BAL, looking at the amount of tryptase that's in the BAL, and it was found to be much higher in patients with severe asthma. In addition, this is looking at CPA3 concentration from inflamed and non-inflamed segments from a patient with inflammatory bowel disease. You can see that in the patients that had inflammation, there was higher amounts of the CPA3, and that this could in fact be blocked as well. Well, in addition to increased density, there's evidence for mast cell activation in EoE. So in that same work from over 10 years ago, they looked at the number of degranulated mast cells. And these were generally considered mast cells that have granules sitting outside of a poorly intact cell body. And when they looked at eosinophilic esophagitis patients, they found much more degranulated mast cells compared to controls. Similarly speaking, you can find increases in mast cell genes, as I've already discussed, and that these mast cell genes are reduced in therapy. You can see FcεR1 receptor, the HDC, which is responsible for the production of histamine, the tryptase gene, TPSAB1, as well as carboxypeptidase A3. And these genes are all increased in patients that have not been treated, or similarly increased in patients that are not responding to treatment, but go down when the patient has responded to treatment. So do esophageal mast cells have markers of rapid mast cell activation? So one of the reasons this is important is that a lot of the measures that we have to date of mast cell and mast cell activation is really at either the transcript level or either the histological level. And one of the problems with both of these is they're more of an assessment of mast cell burden than they are of actual mast cell activation. So in the lab, we grow CD34 enriched human mast cells. These are mast cells that are derived from peripheral blood mononuclear cells and grown in culture for 12 weeks. These cells are grown to purity with a high percentage of them expressing both the IgE receptor as well as KIT. And these cells can be activated with Ig and anti-Ig to degranulate, which is detectable by a beta-hexosaminidase assay. And when you do this, the mast cells have both CD63 and CD107A. These are LAMP proteins, lysosomal associated membrane proteins on their cell surface. And when we look at the kinetics of these proteins, what we find is that CD63 remains present on the cell surface for quite a period of time. You can see 30 minutes, 3 hours, and 24 hours. Still, we have the CD63 present on those human mast cells. CD107A, however, is much more transient and appears very quickly at 30 minutes, but even by 3 hours and 24 hours is much reduced. Well, we looked at this from the perspective of immunofluorescence, and again, this is more looking at probably mast cell burden and activatability and not necessarily activation. But what you see is that the mast cells that co-express CD63, those that are tryptase positive and CD63 positive, are significantly reduced with treatment. And this is much more so, of course, in the patients that had an eosinophil response than those that didn't. This burden also appears to be much lower than that was seen with just tryptase alone. Well, we've now looked by flow cytometry where we've stained mast cells for CD117 and the FcεR1 receptor to identify them and stain their surface with CD63 and CD107A. And what we found in active EoE was a higher number of CD63 and CD107A mast cells as a percent of total live cells, supporting the fact that there are much more activated mast cells present in the biopsy tissue from patients with active EoE than inactive EoE. Interestingly, when we looked at the numbers of actual mast cells, the percent of mast cells, not just the percentage of activated mast cells, we didn't see much difference. And that's not entirely surprising, as we know that mast cells don't always decrease in significant numbers in all patients, as I'll show you more data on in just a second. So rapidly activated mast cells are increased in the mucosa of active EoE patients and decreases with treatment. Preformed mediators released by mast cells have been associated with a variety of functions in EoE and other diseases. This is some work looking at the ability of a mast cell, particularly of tryptase and the blockade of tryptase, to elicit nerve excitement. And what you can see is that there's alterations in nerve potential when PAR2 agonist is applied to the nerve that is different when it's blocked. In addition, Msci has examined the role of both histamine and TGF-beta in its ability to contract muscle tissue and found that both TGF-beta and histamine were capable of causing muscle contraction. My work, we have examined the role of histamine and its ability to recruit neutrophils into the colon. And what we found is that mast cells that lack the ability to secrete histamine, they lack the ability to form histamine as they're lacking the enzyme HDC, have reduced weight loss compared to animals that don't. And in fact, these animals have significant reductions in neutrophils, as well as the cytokines IL-6 and the chemokine CXCL1. In addition, mast cells have been implicated in collagen deposition, in inflammatory bowel disease, as well as work done in eosinophilic esophagitis as well. Well, impaired barrier function is a hallmark of eosinophilic esophagitis. We know from the work of Katzke et al. That when you look at mucosal impedance in patients with active EOE, that you find significantly lower impedance measurements compared to patients with inactive EOE, as well as controls. And this really supports in vivo that mucosal impedance exists. Similarly, when you take a biopsy, and this is work from Dr. Rothenberg's lab, you find increased passage of a large protein, fitzdextran, in a biopsy from a patient with EOE compared to a biopsy from a healthy control. And this is directly associated with loss of the desmoglein 1 protein. And so loss of that desmoglein seems to play a role in the increased passage of the ability of things to pass through the barrier. And now we have an even better idea from some work published recently by Hiramath et al. About what endoscopic findings and what histologic findings seem to relate, so that we have a really clear perception when we're looking at the patient of what mucosal barrier dysfunction really is. And in this work, they looked at the relationship between a variety of histologic parameters and how they related to endoscopic parameters, using a validated system for measuring those parameters quite closely. And what they found, which was very interesting, was a close, was a moderate to moderately significant correlation between basal zone hyperplasia and endoscopic furrows, as well as dilated intercellular spaces and furrows. And we'll talk about this in a minute, but these are really the two hallmarks of epithelial barrier dysfunction. And so this really links furrows, basal zone hyperplasia, and dilated intercellular spaces as sort of the hallmark of mucosal barrier dysfunction in eosinophilic esophagitis. In addition, we know that tryptase and chymase can degrade barrier proteins. So this is some work some years ago published in American Journal of Gastroenterology, in which they incubated HMC1 cells, which are mast cells, with CACO2 cells, which are colonic epithelial cells. And what they found is that giving the mast cells a 1-hour degranulation signal led to a reduction in the amount of JAM-A, which is a junctional membrane protein. And so they found a very significant reduction in JAM-A, and you can see that really here on the right. Here on the bottom right here. These pictures show that tryptase really has the ability to degrade the junctional proteins. In addition, similar work has been performed more recently looking at chymase and its ability to degrade other proteins, including claudin-4, occludin, cytokeratin, and focal adhesion kinase. And so really these proteases have the ability to degrade barrier proteins. This is likely a key function by which they operate in the body. Well, basal zone hyperplasia and dilated intercellular spaces are hallmark findings of epithelial barrier dysfunction in eosinophilic esophagitis. You can see a really classic picture here of the epithelium from a patient with EOE. And the notable findings here are the basal layer hyperplasia, that is the increase in the number of these rounded cells. Normally we see a large number of these flat cells which predominate the biopsy, as well as spaces in between the cells. And it's these spaces that are called dilated intercellular spaces. And it's these two key findings that really point to mucosal barrier dysfunction at the histologic level. Well, epithelial barrier dysfunction in EOE is induced by Th2 cytokines. This has been published by others and we've replicated in the lab, When we expose air-liquid interface, which is an epithelial cell culture, allowed to proliferate and stratify to form stratified epithelium similar to the mucosa of the epithelium, we find a reduction in the amount of tear with exposure to both IL-4 and IL-13, and an alteration in the amount of phytidextrin, the wavelength that gets emitted from passing out from exposure to IL-13. So what this tells us is that IL-4 and IL-13 have the ability to reduce the barrier. Well, this is certainly interesting because, of course, we know that the barrier, there's a big role, of course, in epithelial barrier dysfunction for both proteases and antiproteases. This is from a very nice publication from the Rothenberg lab, looking at all of the various potential proteases and antiproteases that may play a role in eosinophilic esophagitis, many of which have been studied to date, including things like cathepsin-14. Well, epithelial barrier dysfunction in association with EOE symptoms can persist despite treatment that leads to reduced eosinophils. This is from some interesting work by Kelly Whelan et al., in which she looked at patients with inactive EOE. She separated the patients into those that had basal zone hyperplasia and those that didn't. And interestingly, what she found is that the patients that had basal zone hyperplasia had increased total burden of symptoms. So that really suggests that basal zone hyperplasia is a marker of the clinical outcome for the patient. And really, the patients that have persistent basal zone hyperplasia have not had a very good response to therapy necessarily, and may need to be considered for alternative measures. So despite resolution of eosinophilia, mast cells remain increased in density in patients with a poor clinical response to treatment. This is from some work we published last year, and it really builds on that work from Dr. Whelan. So we looked at patients with inactive EOE as well. That is to say, patients that have less than 15 eosinophils per high-powered field. We stratified them into 4 groups. Those that were in clinical remission, they had no endoscopic abnormalities or symptoms. Those were symptomatic but had a normal appearing endoscopy. Those that were asymptomatic but had an abnormal appearing endoscopy, and those that were symptomatic that had an abnormal appearing endoscopy. And what we found is that the patients that had abnormal appearing endoscopy, particularly those that were symptomatic, had the highest number of mast cells present compared to those that were in clinical remission. So mast cells really seem to line up with this mucosal barrier dysfunction and are probably an indicator, again, of a poor response to treatment. Well, this is not entirely inconsequential, as we know that the burden of mast cells actually correlates with symptoms. This is from an interesting study using the pediatric eosinophilic esophagitis symptom severity score, in which both tryptase and kinase gene and expression, as well as the counts on biopsy, were quantified and then correlated with the scores from the Ps. And what they found in that work was a mild correlation of mast cells with dysphagia, suggesting, of course, that the mast cell burden may have a role as a biomarker in identifying these symptoms as being present, and may potentially play a role in driving them, although I think that remains unclear. Well, mast cell density and activation and endoscopic mucosal barrier dysfunction are something that we think are very linked. We've now taken another look at our patients with inactive EOE using semi-automated microscopy. And in this analysis, we've segregated the patients into those with abnormal mucosa, those with an abnormal endoscopic or histologic appearance, and those with a normal mucosa. And not surprising at all, we found very significant increased numbers of mast cells in the patients that had an abnormal mucosa, and those with a normal appearing mucosa looked very similar to non-EOE controls. Now, when we looked more closely at the mast cell burden, we found that there was a significant increase in the number of mast cells the more severe the endoscopy appeared, and that furrows had the strongest relationship with mast cell density. In addition, we looked at the patients both pre and post diet elimination and segregated them into whether furrows were either present or absent. And you can appreciate that among the patients that had furrows present, there was an increased number of mast cells that have CD63 present, suggesting that there's a greater mast cell burden among the patients that have furrows, again, potentially linking mast cell activation to the endoscopic mucosal abnormality. Well, this is also true at the histologic level. And when we looked at the mast cell burden and a histologic score of the epithelium, we found a very significant increase in the mast cell burden with high epithelial histologic severity. In addition, when we've looked at the mast cell burden and its correlation with basal zone hyperplasia scores, we found very significant correlation between mast cell burden, or mast cells have with positive expression of CD63, and their correlation both before and after therapy with basal zone hyperplasia. And we've now looked at the same thing with regards to our flow data. And what we found is also a moderate correlation between basal zone hyperplasia severity and the burden of activated mast cells with CD63 or CD107 present in the tissue. So mast cell burden and activation appears to be a biomarker for pathological epithelial remodeling, even when eosinophils are low. So can rapid activation of mast cells with release of preformed mediators disrupt the stratified epithelial barrier? So in order to analyze this, we took our CD34 enriched PBMC-derived human mast cells, which were cultured for 12 weeks with stem cell factor IL-3 and IL-6 to generate a culture of human mast cells that were greater than 85% pure for CD117 and FcεR1. These mast cells were degranulated for 3 hours with IG and anti-IG, and we collected the supernatant. So in this supernatant is effectively only preformed mediators. We then established air-liquid interface from EPC cells and measured the transepithelial electrical resistance prior to and 48 hours after basal ALI exposure to this conditioned supernatant. And what we found was a significant decrease in the tear 48 hours following this exposure. Now, that wasn't nearly as significant as what happens with IL-13, but it was still very different than IgE alone, and of course different than media alone. And so we really can now see very clearly that the release rate from a mast cell, its preformed mediators are absolutely sufficient to degrade the epithelial barrier. When we looked at how this occurred, we found a significant reduction in the number of cell layers that was similar to IL-13. And similarly, you can see on the right here, the ALI in which IL-13 was treated is very abnormal and somewhat similar to the ALI appearance, the morphology of the ALI treated with anti-IG. So exposure to preformed, rapidly released mast cell mediators is sufficient to disrupt the stratified epithelial barrier. Well, what specific mast cell mediators impair the barrier? And this is still ongoing work in my lab, so I'm just going to present a little bit of the data from today. We've looked at tryptase, and there's of course other data, as I've mentioned, about how tryptase can affect the barrier. And not surprisingly, with increased concentrations of tryptase, we see a reduction in tear after 48 hours. We've also looked at chymase, and similarly, with increasing concentrations of chymase, we see a reduction in tear as well. Now, with histamine, that wasn't the case, and only with very, very high concentrations, super physiologic levels of histamine, do we actually see a reduction in tear. But at much lower levels, and even 100 micromolar is still well beyond the physiologic levels, there's really no significant changes. So not all mast cell mediators impair the barrier, and it really appears to be concentration dependent. But multiple mast cell mediators released by degranulation can impair the stratified epithelial barrier via interaction with the basal layer. And indeed, when we looked at the number of cell layers at following tryptase exposure, we saw something similar to what was seen with IL-13, with a loss of the number of cell layers compared to media alone. So are the downstream changes in barrier gene and protease anti-protease function affected by this? Is it similar to IL-13? Well, there's more to come in that. Well, what does this all mean? Impaired mucosal barrier is a hallmark of EoE characterized by endoscopic furrows and epithelial basal zone hyperplasia. Barrier dysfunction can persist despite low eosinophil counts and is associated with elevated mast cells. Rapid mast cell activation is increased in patients with active EoE and correlates with the degree of basal zone hyperplasia. The release of preformed mediators by activated mast cells is sufficient to disrupt the stratified epithelial barrier via interaction with basal epithelial cells, likely via loss of tight junctions. Whether this leads to increased antigen exposure, acid or luminal content exposure is really unknown. So what's actually driving the mast cell still remains a question, and that is really an important question my lab is attempting to answer. What we don't know. What are the downstream changes in barrier genes, protease, anti-protease function, as I mentioned. Do specific types of mast cells drive basal epithelial function? And we think the answer is probably yes. And are there spatial or regional differences in different cellular compartments associated with these different types of mast cells? Do other proteases contribute to barrier dysfunction? I think this is also an important question. There's much less data in the literature about these other compounds. And do multiple proteases work in concert? And then finally, what are the drivers of this mast cell activation? And I've listed some possibilities that I've already mentioned. Just want to give a quick thank you to everyone that's really supported me in this process, the members of my lab, as well as my mentors. Dr. Bachner in particular has been my primary mentor, Dr. Schleimer. I really want to thank Seeger, Dr. Rothenberg, Dr. Fruta. They really gave me support behind Seeger to initiate my career as an EGID investigator, and as well as my collaborators. And with that, I can happy to take any questions.
Josh, that was fantastic talk. And I have my own series of questions, but I'm going to go through the Q&A, and then I'll email you separately. So one question that came in early on, and you I think partially addressed, but very interesting question. It says EOE appears to be triggered by specific antigens, and the role of IgE in EOE has been refuted or at least disputed. If mast cell activation drives esophageal barrier dysfunction, how are they activated in an antigen-specific fashion?
That's a fantastic question. I don't think we know if they're activated in an antigen-specific fashion at this point. And I think that remains an outstanding question. I mean, the general concept of how a mast cell gets activated is via IgE, but when you block IgE alone, it's definitely insufficient to treat eosinophilic esophagitis. I think in your study, Kathy, looking at omalizumab, you saw a slight decrease in symptoms. And even others have looked at the use of cromolyn topically and seen a decrease in symptoms. So there may be a component of eosinophilic esophagitis that is being treated when we block mast cell activation, but it's probably insufficient in and of itself. And whether it occurs at an antigen-specific level is truly unknown.
Fantastic. I think we only have time for maybe one or two more, and I'm going to try to hurry through this. And again, like I said, Josh, I'll find you offline myself. But is there an impact of modulating Siglec 8 on mast cells in patients with EOE?
I think that the data is still out on that, and there's a clinical trial ongoing that I think will help to answer that question. So I think that probably should be unanswered at the moment.
Next question. I'm trying to get through these quickly because you inspired a lot of interest here. It is very clear that mast cells can affect epithelial barrier. I wonder if epithelial cells can modulate mast cell activity. Would you care to comment on that?
We think the answer is most likely yes, that the epithelial cells are likely giving off signals that are in fact affecting the mast cell. Yeah, they're likely one of the key reasons why a mast cell is being activated.
I think we might have time for one more. I'm going to try to hurry through this. Do you have a model for how eosinophils and mast cells may interact or have duplicative pathways in EOE?
Do we have a model in the lab? We're seeking collaboration with others who are expert in growing eosinophils. That's not something that we're good at in my lab, but I think it's an important thing that needs to be studied.
That's fantastic. I think we're unfortunately out of time. I think we can try to address some of these questions a little bit later. It was fantastic, Josh. It was great for me to listen to you, and I will definitely catch you via email after this. I'd like to introduce our next speaker, who I actually follow. Being a clinician, I tend to try to read everybody who's way smarter than I am, so to learn about my disease state that I'm taking care of. And I'd like to introduce Lisa Spencer. She is going to talk on intestinal tissue eosinophils and health and inflammation, heterogeneity, plasticity, and regulation. She's an associate professor of pediatrics at the University of Colorado School of Medicine and likely about to get the snowstorm to just hit Salt Lake City, and the scientific director of research in the Gastrointestinal Eosinophilic Diseases Program. And I am excited to hear her talk today discussing eosinophils.
Thank you. Sorry. There we go. I think we're up now. So thanks for that introduction, and thanks so much, Mark, for putting this together and inviting me to have this opportunity to share some of what we're working on. We're going to change gears a little bit from what Josh was talking about with EOE and really look at some of the EGIDs that are lower than the esophagus or lower than the diaphragm. And so one of those important things that we need to remember when we're talking about the lower GI tract compared to the esophagus is that the eosinophils from the stomach to the rectum are there in health. So we have high numbers of eosinophils that come in even at baseline. It's actually the highest reservoir of eosinophils in a healthy individual. And they tend to be doing good things. So they're promoting innate and adaptive immunity, metabolic regulation, and tissue homeostasis. And so this is really at odds with the condition with EGIDs, with gastritis, enteritis, and colitis, where you have this increased infiltration of eosinophils that tend to have pathogenic effector functions. And this is more tissue destruction and fibrosis. So the question really comes out then, do we have the same cell that's doing good things and bad things, or do we actually have good eosinophils and bad eosinophils? And I think if you've been watching the literature in the field, we really are having this idea of eosinophil phenotypes coming up over and over again. And so looking at the lung models, this is really where we have the most information about these functional subsets. And this is mainly from mouse data here, although I did use a picture of a human lung, sorry about that. So in the normal airways at baseline, we've got populations of resident eosinophils that are regulatory eosinophils. And there are several papers that are now showing this kind of an effect, and they're actively homeostatic. They're actively dampening Th2 immunity. And this is in contrast to allergic airway disease, where you get this inflammation or infiltration of recruited eosinophils that are clearly inflammatory. So they are exacerbating Th2 immunity. And these cells have some morphological differences. They cluster a little bit differently. So there's some things that you can say or point to that are differences, but also their surface phenotype is very different. And the one molecule that I'll mention, because it relates to what we're talking about today, is in regulatory eosinophil is CD11C negative, and this is an adhesion molecule, whereas an inflammatory eosinophil in the lung upregulates at CD11C and is CD11C positive. And so one of the questions that my lab is really trying to ask is, can we define intestinal eosinophil heterogeneity and really understand this? Because we think that this is going to provide key insights into disease pathogenesis. We think it'll give us insights into how we might be able to monitor disease treatments. And also we're hoping to get some insights into developing some eosinophil targeted therapies, which can predominantly attack the inflammatory eosinophils and sustain those homeostatic or protective functions. And so why can't we just apply what we've learned from the lung to the gut? Well, I think we all realize on this call that the gut environment is very different. And so there are clearly complex systemic and local pressures that are acting on these cells, constantly shaping and reshaping the intestinal eosinophil compartment. These eosinophils in the gut are also living for quite a long time compared to other organs. This is up to at least 2 weeks. And so we have just the opportunity to differentiate into many different types of cells. And all of this comes together to really create a highly heterogeneous eosinophil population in the gut. And this is even at baseline. And I think one of the pieces of evidence that has made this very clear, and this is coming out of several groups now, but Oliver Papp's group was the first to publish in 2009, eosinophils in the gut constitutively express CD11C. So again, that's that adhesion molecule that I talked about in the lung, which is a marker of inflammatory eosinophils. So even at baseline, we see this constitutive expression of CD11C. So one of the first indications from our group that there really is quite a bit of heterogeneity within the intestinal eosinophil pool is our recognition that in addition to these lamina-appropriate eosinophils, we routinely detect eosinophils within the intraepithelial compartment as well. And so we can show that these cells are truly in between epithelial cells, but we also see a population that flattens itself out along the basement membrane and takes short dendrites and pokes them through that basement membrane into the intraepithelial space. So we think both of those cell populations are contributing to this intraepithelial eosinophil population, and we can detect these cells in both mice and in humans. And if you look at bulk analyses of these intraepithelial cells and just compare them to the lamina-appropriate eosinophils, we can begin to see differences in the overall level of surface marker expressions. And so again, these are bulk populations and you're looking at just the delta mean fluorescence intensity, but we're specifically interested in some of the patterns of those expression. And so for CD11C in particular, you can see a pretty big range between these two cell populations. But when you look at the histograms here, it becomes very clear that these are not distinct populations. Rather, you have this multimodal peak, particularly in the lamina propria. And so looking at this pattern of expression, we really walk away with the idea that there's a continuum of activation or a continuum of expression, particularly of CD11C, and there is quite a bit of overlap between this lamina propria and intraepithelial compartment. So in thinking about this, we started to look at lamina propria eosinophils from a number of different background strains of mice and in different conditions. And if you look at the contour plots, we began to notice that there were clear, dense focal populations that allowed us to sort of arbitrarily place these gates. And so what we've done is we've divided the lamina propria eosinophil population into CD11C low, intermediate, and high, and we can apply the same gating strategy to intraepithelial eosinophils. And it really shares this idea that the CD11C intermediate population seems to be dominant in both of these compartments, but the lamina propria eosinophils also are highly enriched for CD11C lows, and so these would look much more like blood eosinophils, whereas the intraepithelial compartment is enriched for the CD11C high expressing eosinophils. And so we do think that this is a continuum of expression. And so we've hypothesized that you're going to see other overall level or markers of eosinophil activation also increasing along the same stepwise expression. And so we gated on these different CD11C low, intermediate, and high populations, looked at the relative expression of some other activation markers. And as you can see here, they do in fact show a stepwise increase in both Sig-like-F and CD11B. So we do think that this framework of CD11C defined subphenotypes does align with the overall eosinophil activation status. So this is allowing us to now look at the lamina propria and the intraepithelial compartments in a different way and to get a picture of how inflammatory we think these eosinophils as a compartment are. And so when we do this for BALB/c wild-type mice, we begin to create these plots. And so this white bar, again, in all of these plots, you can think of these as putatively non-activated or the closest to blood eosinophils we have, whereas these bright orange bars are really going to be more of the CD11C high expression, what we think are probably much more inflammatory eosinophils. And so the first test that of course you want to do is to look at these cells in an inflammatory model. And so we use the transgenic TNF delta ARE mice. So these mice overexpress TNF alpha and they have a chronic inflammatory response in the gut. They spontaneously develop ileitis by 8 weeks of age. And so if you compare TNF delta ARE lamina propria eosinophils shown here on the right to their wild type littermate controls on the left, you can see there's a significant loss of those putatively homeostatic eosinophils, and rather there's a qualitative shift to really favor these inflammatory phenotypes. So we think we have a framework to start to monitor the relative inflammatory responses of eosinophils. So what does this look like in an EGID model? So for the EGID model, we're really using basically a food allergy model. And this is the same model that was used, or a rendition of it, in the preclinical mouse trials for anti-Sig-like-8. And we've modified it a bit here in this image for BALB/c, and I'll explain why in a minute. But basically, this is the ova alum model. So we do IP sensitizations with ova mixed with adjuvant alum. We then follow that with 3 intragastric exposures to ovalbumin, and then 1 or 4 days after that final allergen challenge, we go ahead and sacrifice the mice. And I will say this is a BALB/c mouse, so we only need those 3 allergen challenges in order to get an increase in eosinophils. If we continue this out to 6 or 9 challenges, you lose some mice to anaphylaxis. If you're doing this in a B6 model, though, and any data that I show you from B6, you can just imagine that this is extended out 2 to 3 additional weeks because you need those 6 to 9 oral gavage challenges. So at these 2 different time points, we're also in some of these studies going to inject with BRDU for pulse labeling. So eosinophils are terminally differentiated when they come out of the bone marrow. So your BRDU positive cells are bone marrow derived eosinophils that have entered into the intestine. So at each of these time points, we're going to go ahead and analyze by histology. We take rings from the center of the jejunum. We quantify the eosinophils both by total eosinophils per crypt villus unit, as well as looking at where they are, whether they're in the lamina propria surrounding crypts versus in the lamina propria coming up the villus. And then we'll also in parallel take the rest of the small intestine, digest it, and look at these CD11C defined subphenotypes. And so when we do this in our food allergen model, you can see that within 1 day of food allergen challenge, or the final food allergen challenge, you do see a significant increase in eosinophils. It is not further increased 3 days later, but there's no reduction either. So it's about the same level. So although these levels stay the same, when you start to look at where in the tissue these eosinophils are, you can see that at day 1, when you have this infiltration of eosinophils into the gut, they tend to be predominantly within the lamina propria surrounding the crypts, and then they're redistributing into the villi. And if we look at their CD11C subphenotype populations at the same time point, we can really see that that day 1 infiltration into the lamina propria surrounding crypts is enriched for these CD11C low eosinophils. And again, this makes sense because the CD11C low is the phenotype of the blood eosinophils. And we can confirm this using our BRDU tracing studies. So in saline-treated mice, there's a very low level of normal migration of eosinophils into the gut. These are all CD11C negative or low. In the presence of the food allergen challenge, you can see a significant induction of these BRDU positive eosinophils coming from the bone marrow. And they all also fall within this Sorry, I'm not sure how I just got muted. So these are all the CD11C low population that the BRDU positive eosinophils fall into. And you can see by the histology staining that those BRDU positive eosinophils really are localized to this lamina propria surrounding the crypts. And if you look 4 days later, now you can see that BRDU positive eosinophils have upregulated their CD11C. So in parallel with moving up the villi, in situ, the eosinophils are inducing their CD11C expression. So we do have plasticity at least in one direction along the CD11C continuum. So one of the things that was interesting from these experiments and actually surprised us is that in addition to these changes in the lamina propria, we were also seeing a transient induction of CD11C low eosinophils showing up in the intraepithelial layer. And so again, this surprised us because we do not generally see CD11C low eosinophils in those IE preps. And we can confirm with our BRDU tracing studies that these BRDU positive eosinophils were in fact CD11C low. So we can confirm it with both approaches. But it made us pay a little bit more attention in our parallel studies with eosinophil reporter mice, looking at what's happening outside of the gut tissue and in the actual lumen of the gut. And so what we noted was about 4 days after these food allergen challenges, we started to see increases in the number of leukocytes that we were seeing in the luminal space. Most of these cells are not eosinophils, but about 2 to 4% were eosinophils, and we could often catch eosinophils apparently transmigrating across the epithelial barrier. So we looked at these luminal eosinophils by performing intestinal lavages on the entire small intestine of these animals. And again, these are B6 reporter mice. But when we did the phenotyping, we could see the vast majority of luminal eosinophils were actually CD11C negative or low. So we thought this might be an artifact of the B6 system. So we did go ahead and repeat this in BALB-C cohorts of animals. We can start to see more of the CD11C intermediate eosinophils in the lumen of the BALB-C mice, but we still see this very strong population of CD11C negative low cells. And that's intriguing because, again, this looks like the pattern of expression that we saw in the lamina propria compartments much more than what we saw in the intraepithelial. So these luminal eosinophils seem to mimic the LP compartment more than the IE. And so what we can summarize from this first part is that intestinal eosinophils, it seemed to exhibit a continuum of CD11C expression. So we do not see this binary regulatory versus regulatory versus inflammatory that we see in the lung, but rather we seem to have this continuum of expression that roughly aligns with other indices of activation. And we can develop this gating framework, which helps us to see qualitative and quantitative aspects of the intestinal eosinophil compartment. And this is sensitive enough to start to see some of these shifts, even in the context of acute allergic and chronic inflammatory diseases. And when we look at this, these samples in this way, we can start to begin to picture the CD11C negative low eosinophils coming out of the blood, getting into the lamina propria surrounding crypts, and then upregulating their CD11C in situ as they migrate up the villi. We also feel that we have a population that can be a transient population induced by allergen that is a CD11C low population that undergoes transepithelial migration, and this is distinct from the CD11C high resident interepithelial eosinophils. So can we use this system to start to try to have some therapeutic approaches to getting rid of the inflammatory eosinophils while we maintain our homeostatic eosinophils? And so one of the areas of research that we're looking at in this way is Notch signaling. And so my group has published a bit on Notch signaling in the past, specifically Notch1, but we've also looked at Notch2. And so Notch signaling is an evolutionarily conserved pathway that regulates sulfate decisions in a number of cell lineages. In the canonical signaling, your receptor is going to be activated by a series of sequential cleavages that eventually release this intracellular domain, which has transcriptional activities. And we can see in human eosinophils, these are healthy donors. The Western blot is for Notch2 receptor, and we can see not only the full length, but very strong bands for these potential cleavage products. So we think Notch2 receptors are constitutively expressed and activated in human blood eosinophils. And so we went ahead and took human eosinophils, again, from healthy donors. We stimulated them in the lab with IL-3 and induced an activated transcriptome. And you can see that here on the left from eosinophils from 4 different donors. If we added anti-Notch2 inhibitory antibodies to these cultures, you can see a pretty significant change in the activated transcriptome. So many of these genes are downregulated and a few are upregulated. And when we look at these differentially expressed genes and we ask which pathways they might be involved in, we have a number of hits that are involved with eosinophil survival and apoptotic pathways. And so we took these cells in the lab and really looked at the eosinophil survival. And if you culture eosinophils overnight with no growth factors, you get about 60% survival in the morning, and that's what you see here. And the presence of these anti-Notch2 inhibitors really had no impact on this viability. If, however, you go ahead and give some growth factors to these overnight cultures, you can maintain your viability up closer to 95%. And what was intriguing is if you include an anti-Notch2 inhibitor under these conditions, you completely lose the cytokine-mediated survival effect of these eosinophils. So we became very excited in this idea that targeting Notch signaling, specifically Notch2 in eosinophils, might putatively eliminate these inflammatory eosinophils while sustaining the homeostatic, or at least leaving the homeostatic eosinophils alone. And so to test this out, we used the EO-CRE mice from Jamie Lee and Beth Jacobson. We crossed them to Notch2 floxed mice. We call these EON2 mice. This is an eosinophil targeted ablation of Notch2 receptor. We've shown that these mice are viable, they're fertile, their Notch2 is deleted in eosinophils, but not in anyone else, and they have normal distributions of eosinophils in the bone marrow, blood, lung, and small intestine. And you can see that here for the intestine, these are wild type lamina propria eosinophils versus EON2. These are manual counts. And so they're the same number of eosinophils, and they're also their distribution between the crypts and the villi at baseline is the same. But when we expose these animals to 6 challenges with the EGE model, you can note that we see a significant reduction in the overall number of jejunal eosinophils. And this is entirely due to this loss of villus migrated eosinophils. And you can see that by the quantification in the bottom, but you can also see it in the images. This is DAB nickel staining of eosinophils up near the tip of the villus in wild type mice induced by allergen. In the EON2s, the villi are predominantly clear of eosinophils. And so if we look at the lamina propria compartment by the CD11C subphenotypes, you can see we have a strong enrichment for these putatively homeostatic eosinophils in the EON2 mice and a loss specifically of those CD11C high. So we can really add to our growing picture here that Notch2 signaling is necessary in human eosinophils, both for cytokine-mediated survival as well as that activation phenotype. And we can show that if we target the deletion of Notch 2 just to eosinophils in a mouse model, we can prevent this induction of CD11C and villus migration in vivo. And so with that, just want to thank all the people who have made this possible. Stephen Schwer was a resident in my group when we were back at Beth Israel Hospital. He did a lot of the human studies for this during his residency, his AOC rotation time in the lab. And Courtney, you know, she was an undergraduate student doing an honors thesis in my group, and she generated those EOCRE N2 mice and validated them. So those two in particular, but certainly a whole village to make this work come together. So thank you so much.
Lisa, that was fantastic. Thank you so much for giving that talk. And I always, being a clinician, always try to relate this to what I see, you know, eventually down the road in my patients and how it's going to, you know, influence how we treat these diseased patients. There are a few questions that came in, and I was hoping I could kind of relay them to you. There was one question about colonic eosinophils. So the question relates to the fact that colonic eosinophils are CD11C low in mice. So the question is, do you suggest that maybe they're less activated?
That is a great question. We do see different levels of CD11C expression on colonic eosinophils. So you're right, compared to the small intestine, they do tend to be CD11C lower, but we can also see them upregulate that CD11C expression as well, particularly in their colitis models and IBD models in the lab.
Great. And this is actually a question that I had as well. So this is interesting. So connecting you with the last speaker, do you see any mast cell changes in your EGID model? And what happens to CD11C in the eosinophil bone marrow in vitro culture? And finally, this is a little bit more than what I was thinking, but finally, do human intestinal eosinophils also express CD11C? And I can read them over again if you need me to.
Those were great questions. And so the first question, if you can just remind me what that one was.
Oh, the first question, sorry. This has to do with, do you see a relationship? So are you seeing mast cell changes in your EGID model?
Yeah, this is a great question, and it is definitely on our to-do list. We don't know is the short answer to that question. So we are looking at it in two ways. One, looking at degranulation of mast cells and how that might relate to the level of CD11C and expression on eosinophils. But also we're trying to get at this from more a spatial aspect as well. We'd like to understand if eosinophils are talking to mast cells, and if your different levels of eosinophils as you go up the villi might impact mast cells differently as, again, you move up the villi. And we really don't have those answers yet.
Those are, I mean, these are all things that we're all wondering. And the question was for Josh as well, very similar to this one before. I guess the segue on the second part of that question is, what happens to CD11C in the eosinophil bone marrow in vitro culture?
Yeah, I don't know. We haven't done the bone marrow culture recently since we have a better understanding of what's happening with CD11C. My guess is because the eosinophils coming out of the blood, even in our EGID model here in the lab, they are still CD11C negative. So I really think that in our model, the induction of CD11C and the upregulation is happening in situ within the intestinal tissues. I think, you know, when we start looking at patients, we need to be a little bit more careful because there have been some reports of, you know, blood eosinophils starting to upregulate some of these adhesion molecules, and that might happen more quickly than it's happening in our mouse models. And that's one of the questions we have with our patient blood samples here, is to really look in parallel and ask, you know, are we comparing apples to apples, or do we really have to be careful about when and where these adhesion molecules are upregulated? It's a great question.
And that kind of segues into another, I'm kind of bouncing back and forth. You have a lot of questions. I don't know if we'll get through all of them, but is the CD11C functioning as part of the transepithelial migration?
No, that's a fantastic question. So I don't think so, because again, these are CD11C low eosinophils. And I should note, you know, we can't prove that CD11C is not just being cleaved before it leaves the epithelial layer. I don't think so for a number of reasons, but we certainly can't prove that. But one thing that I did not mention in the data, but that we do know, is when we look at the CD11B expression on these cells, they are uniformly high. So they're CD11C low, but they're CD11B high once they get into the intraepithelial space and are transmigrating across. And so I do think CD11B is going to be required for transepithelial migration. And there's a paper that's out from Sean Colgan and Peter Weller that looked at that. while I was still in high school. Sorry, guys. But so it was really, I think that is something that is now coming back to the forefront, and we are going to find is an important adhesion molecule as well.
Great. A follow-up question, this is interesting. Gamma secretase inhibitors block Notch signaling. Can they be used in an animal model?
Yes, they can. The problem with GSIs, and so this came out of a lot of the cancer data, when you globally block all Notch receptors with a gamma secretase inhibitor, there is some pretty significant intestinal toxicity that happens. And so we can do that. We have done that in vivo in our mice, and we can see some different changes. But what I'm excited about with the Notch2 is if we specifically block one receptor, so just Notch2, you avoid the intestinal toxicity. So I do think GSIs could be important, but I think that really coming at this from single receptors is going to be the way to go therapeutically to avoid some of those other negative downsides.
Fantastic. There's a few more. I'm hoping I can get through them. Well, first of all, a comment, great talk. Do you see differential CD11C expression by eosinophils in different segments of the small intestine? And are they more or less enriched in the duodenum versus the ileum? That's a great question.
Yeah, I might just have to play this recording for one of my technicians, because, I'm having her cut these intestines up into such small pieces and then go through the entire gut prep procedure, which for us is pretty laborious and intense. And at the end of the day, sometimes she doesn't get enough from these very small pieces. So we are trying to ask that question. And I do think we are going to see differences. We certainly see differences in the localization of eosinophils. And I'm assuming in some cases what we're seeing is as you have more microbial just insults closer to the ileum end, that's part of it. So a lot of this is different markers, CD11C as well as PD-L1, CD80, some of these other markers as well. We are seeing differences along the length of the intestine. It's just as we ask these questions and get fewer and fewer centimeters to deal with, and then add more receptors on there, we're having a hard time really getting the strength and the numbers to answer these questions. But we're getting there. And the quick answer is yes, there are differences along that length.
Great. Sorry, I'm trying to get through all of them. There's so many questions because you've stimulated a lot of thought. So do you feel that there's a continuum in terms of differentiation of intestinal eosinophils or distinct subsets?
Yeah, so I think that we can't prove it either way. So I should just put that caveat in there. My personal feeling is it's a continuum. I think we're going to have a very hard time identifying specific kind of quote unquote subsets and be comfortable with that definition. That being said, even within those different CD11C negative, intermediate, and highs, there is quite a bit of heterogeneity and variability. So we are building a panel of markers right now that we have identified to be differentially expressed. And even within those compartments, we're seeing quite a bit of variability. And I think if you look at the single cell RNA-seq data that has come out of several groups now, you really see how much variability there are, depending on how you want to parse these populations out. But my personal opinion is what we see is it's a continuum of activation, and I only see it going in one direction right now. I really haven't been able to flip a CD11C high eosinophil back to a CD11C low. So I do think right now the data points to a one-way path. Whether they all take that path or some are kind of leaving, again, these transepithelial migrating eosinophils are not upregulating their CD11C. So I think there are multiple paths they can take, but I do think it's a continuum and not so much a binary regulatory versus inflammatory, at least in the gut.
Great. I think we have time for one last question. And so forgive me if I slaughter this, and then I'll have you kind of look through the Q&A and answer because you have many more coming your way. In parallel with what you were discussing with respect to differences between acute and chronic inflammation, this is reminiscent of Preston's work on the PETH2 cells kicking in when inflammation is sustained. Do you think that these PETH2 cells could contribute to the maturation of CD11C positive eosinophils?
That's a fantastic question. And I think we're going to have to really unpack that. And we have some tangential projects in the lab that could get at that. And I think, unfortunately, stay tuned 6 months to a year, I think, to have that answer.
If only we had like an hour for everybody today. Right. But thank you for that fantastic talk. It was absolutely intriguing. I am going to move us on to the next and final talk. Last but not least, I'd like to introduce Wayne Shreffler, who is the director of the Food Allergy Center, Massachusetts General Hospital, and the division chief of pediatric allergy and immunology at Mass General. He's also the principal investigator at the Center for Immunology and Inflammatory Diseases at Mass General and the principal investigator at the Food Allergy Science Initiative of the Broad Institute. And we have been very fortunate to have him come talk today on evidence for antigen-specific conventional CD4 positive T cells in EoE disease. Thank you very much.
Thanks. It's really great to be here, Kathy, and thanks for the invite, Mark. And these are great talks. I also wish we had an hour, at least for the previous two. I'll try to stay on time for mine. Let me get the slides. And I appreciate the opportunity as an interloper to talk about CD4 T cells. Did that follow to the presentation? Or are you seeing the, let me confirm here.
Looks good.
Okay, great. So we're going to shift gears again and talk about adaptive immunity in EoE predominantly, but I'm going to try to sort of take the opportunity, especially since these data are just recently published, to talk a little bit about, how I think of EoE as an important model for understanding food allergy more broadly, and sort of make a pitch of a central role for CD4 T cells broadly, and similarities between phenotypes of food allergy. And I wish actually, Lisa, I got some interesting, eosinophil data too, and on that last question about interactions between Th2 and eosinophils, I hope that's the kind of thing that this group may find interesting, although I won't have much to present here. So making the case of EoE as an antigen-specific disease on the face of it may be, not controversial at all. Kathy and others have done a lot of work to show that as a clinical disease, this is very often food dependent, and though not IgE dependent, and these highly differentiated, these polarized so-called pathogenic effector Th2 cells, if we accept that as sort of a common phenotype across a few different diseases, as I tend to, have been consistently associated with sort of stronger and stronger data. But on the other hand, much of the data that we have in terms of systems biology really puts the epithelial unit at the center of disease pathogenesis, of course, along with the eosinophils and mast cells. And that although, this pathogenic Th2 subset is our conventional alpha beta T cells, they do express features that are innate-like and may be certainly responsive, and in some data have been shown to be responsive to alarmins. And so it's, I think not at all controversial, or not at all not controversial to suggest that their primary role is in direct sensing of specific antigen, even though we often, phrase things that way in introductions to papers. In fact, prior TCR analysis has not really revealed particularly striking features of antigen specificity. And so when we started out on this, this became our pole star. These data from Mark's lab came out not long after we started doing this work. And they did fluidine-based single-cell RNA-seq from EoE, a total of about 20 people, 6 in remission, 11 with active disease, profiling about 1,000 cells, and found, these populations shown here in the TISNE clustering as T7 and T8 to be upregulated in active disease. And in particular, really, this population clustered here as T8 that corresponds, I think, really nicely, and in fact, extended our knowledge of this cell type, this pathogenic conventional CD4, highly Th2 skewed cells with prodigious production of the machinery to produce PGD, and that may be important for interacting with other cells, as well as multiple Th2 cytokines, et cetera. And the T7s look more like Tregs. And uniquely at the time, although building on earlier data, certainly they really showed very beautifully, this central set of genes involved in lipid metabolism as being really a hallmark feature of these Th2 cells. So that was sort of became the context for our work. We did seq-well-based single-cell RNA work in collaboration with Chris Love's lab at MIT. At the time in particular, this was a really advantageous platform rather for getting paired TCRs. It also helped us phenotype some eosinophils, which has remained hard to do on some other platforms. So we had 6 active and 4 remission EOE patients and profiled about 30,000 cells altogether. And I'm really going to focus here on the brown colored, it's a terrible color, central cluster of CD3s. And consistent with the data I just showed you, most of these are actually CD8. A subset here are CD4s scattered between populations that look like Th17 or Treg, or indeed this cluster of pathogenic Th2s with sort of hallmark multipotent cytokine production, GATA3, hematopoietic PGD synthase, IL-25 receptor. Here's the fatty acid receptor that was sort of a central feature of the Wen paper that I just showed. Again, we could replicate their finding of this whole cassette of lipid metabolism related gene expression. And indeed, this has not only now been shown by our groups, but also in other disease contexts. This is some reanalysis of these other data sets that's in the supplement of our paper. And you can see this in single cell data that was actually published in the same article in atopic dermatitis, in chronic rhinosinusitis by a group at the Broad. And so this really, I think, emerges as an important and with a lot of, I think, follow-up work demanded to kind of understand the regulation and importance of those genes. But we were curious to sort of leverage, what we could about antigen specificity, and to do that, we profiled in parallel peripheral blood from these subjects. This is with polyclonal activation, identified, increased expression of CRTH2 in general, as well as double positive CRTH2 161. Sorry, I'm just going to go back by flow. So this modest increase in the small number of patients, I think this is real, and I think there's other data to, that's consistent with this. This is not looking at an antigen-specific response. And this is the corresponding seq-well data of these CD4s. And you can see kind of this gradient of expression. So the t-SNE is not particularly revealing, but it does show sort of this gradient that I want you to keep in mind toward clusters 3 and 2 that are double positive increasingly for CRTH2 and CD161. Keep that in mind as we look at the repertoire data and other things. This is really the population that best mimics in the peripheral blood this PETH2 phenotype by virtue, for example, here of the lipid metabolism gene set, as well as strong sort of multipotent production of Th2 cytokines and surface markers that we're familiar with. And that lines up well with what's in the tissue. The cytokines are hotter because we've stimulated the cells. And in the tissue, the lipid metabolism genes appear to be more strongly expressed. So looking at the clonotypes, we were able to recover TCR betas in about 50% of these cells. This is about from the esophagus, around 4,500 cells altogether. And when we start drilling down into these subsets, we're getting into hundreds to low thousand number of cells. Paired alpha beta in only about 20%, beta in about 50, alpha in about 40%. And you can see kind of corresponding with this gradient of the PETH2 surface phenotype, and as well as I've shown you other features of that phenotype, that the peripheral blood T cells are much more expanded and oligoclonal when derived from these pathogenic Th2 subset of CD4s in the periphery of these patients. The other markers or analysis we did to sort of emphasize evidence of antigen specificity is shown here, decreasing Shannon diversity, as well as using Mark Davis's glyph, which allows you to take into basically homology of the TCRs, looking for evidence of clusters. We did not incorporate HLA information, although that's also possible using glyph2. And finally, asking the question, can we see tissue TCRs in this peripheral expanded PETH2-like phenotype of cells? And indeed, we found examples from 2 of the patients in active disease, almost exclusively within the pathogenic Th2, although some are shared also among conventional Th2s. So if we do differential gene expression, asking what's really different between these cells that do or do not bear TCRs that are found in tissue as a marker of antigen specificity, in addition to some T cell V genes, the other thing that pops out is GPR15. And that was unexpected. LRP12 may be involved in signaling. It's involved in G-coupled protein receptor signaling in general. So what is GPR15 and what's known about it? First of all, we could show that now doing allergen-specific stimulation of the peripheral blood of patients, a subset that were responsive in terms of their clinical disease to milk, we could show that the allergen-specific response, and this is subject to some bystander activation, this is looking at 154, but that antigen-activated response enriched for specificity. And some other work we've done, comparing TCR clonotypes in activated versus unactivated cells, we estimate true antigen specificity to probably be somewhere around 15 or 20% of these cells. That it's strongly polarized toward a Th2 phenotype and is GPR15 positive, modestly increased GPR15 expression on those cells, in fact. And that corresponds to what we see of the CD4s in tissue, where in fact, a high percent, about 50% of them express GPR15 in the tissue. Looking across CD4 subsets in the RNA-seq data, we could see, in fact, as expected, alpha-4 beta-7 expression on the T cell subsets, both CD8s in E1, E2, for example, and as well as in the small bowel in the duodenal biopsies. CCR9 exclusively expressed in the duodenal biopsy T cells, and GPR15 most strongly expressed, in fact, in that pathogenic Th2, but not restricted to that, and also present on the Tregs and other CD4 populations. And corresponding expression of the ligand is shown here. So esophageal epithelial expression of GPR15 ligand exclusively, and corresponding for CCR9 expression of CCL25 in the duodenum. The expression appears to be from the epithelium of the ligand, that is in epithelium, in the basolateral and perivascular. It is not, we're not convinced it's really different in active disease or significantly different at this point. It seems to be constitutive. So certainly these cells are well poised to play a role in active, in helping to drive disease. And this was just some examples of expression by Th2s of a number of ligands that would be expected to have signaling potential and interaction with eosinophils, mast cells, et cetera, including cytokines, chemokines, integrins, et cetera. So that was sort of beautifully summarized by Dr. Rothenberg and colleagues in a companion editorial. And so I'll use this to sort of, summarize our thinking about this, which is that, this subset of pathogenic Th2 cells that are GPR15 positive are the ones that are really enriched in tissue and we believe likely antigen specific and capable then, along with other signals, no doubt, of infiltrating the inflamed esophagus and helping to play a role in driving disease. So questions for us, we think, are, how generalizable is this? Is this a feature, for example, of allergen-specific EOE? Is it a feature of EOE driven by other food antigens or somehow unique to milk antigens, et cetera. What helps to determine this end organ specificity? It's known that GPR15 is important in trafficking of T cells to other mucosal tissues, particularly the colon. We're very interested in ways we might be able to exploit this finding for improved diagnostic approaches and that could be less invasive if we can exploit increasing knowledge of TCR repertoire and its relationship to antigen specificity, for example. In terms of GPR15 as a potential therapeutic target, I think we need to understand the biology much more. How is it regulated? And ultimately, you know, where does this antigen-specific immune response develop? And so one of the things, you know, over the years that I've been impressed by, having spent most of my time, you know, studying IgE-mediated food allergy, has been the observation of this cell subset or cells that certainly look very much like it in what we think of as a pure IgE-mediated hypersensitivity. And so this is work of Eric Wambre, you know, really showing a phenotype that he named here Th2A, double positive for CRTH2 and 161, responsive after in vivo challenge with food allergen, that looked a lot like, you know, Cal Prussen's initial descriptions of the PETH2 phenotype. And so, again, from Eric's paper, showing, in fact, a comparison of conventional Th2s against these Th2As really being identified by a lot of these same hallmark genes, PPAR gamma, CD25, or IL-25 receptor rather, and additional Th2 cytokine expression. And indeed, we know that there's overlap, you know, from genetic work, you know, between food allergy and EOE, and even suggestions of counter-regulation between the two, observed particularly in recent years by the fact that EOE is a common adverse event associated with OIT. So we wanted to look at OIT, and a lot of the work in the lab is focused on peanut allergy and other IgE-mediated food allergies. And so we've also done sequel analysis of CD4 T cells from the periphery of patients as they're undergoing these treatment protocols, and really trying to take advantage of the heterogeneity and outcomes that are observed from people that achieve something that resembles tolerance, not true tolerance. If they avoid antigen a long time, many of them will become reactive again, but they have sustained protection. They can go for weeks or months without ongoing allergen exposure, versus patients that really just achieve a level of desensitization. They require ongoing allergen exposure to maintain a higher threshold before having immediate reactivity, versus patients who fail in high percentages due to gastrointestinal adverse events. And profiling the CD4s here, we really took an unbiased approach using an unsupervised PCA to assemble gene set modules that corresponded to different CD4 clusters. You can see the heat map showing some representative expression in either the 137 positives enriched for Tregs versus the effectors. This is after antigen-specific stimulation exclusively versus the resting double negatives. And so we sequenced both resting and the individual single positive populations here. They have a largely distinct TCR repertoire. It has many hallmarks of antigen specificity, as one would expect, including expansion and lower diversity, et cetera. And in fact, within, in particular, I'll highlight the Th2 cells. There are multiple subsets of Th2s, including these Th2As, as well as the recently described follicular helpers that we can catch in circulation that have strong Th2 polarization. Some of that shown here. It's really the TFHs that correlate with serum IgE, as one would expect, whereas the Th2As don't have any association to that. And skipping through this paper to kind of get to the point of including it here if we ask in sort of unbiased analyses, what are the predictors among these gene set modules for OIT outcomes, there's really two things that emerge. On the left, after treatment, the treatment failures really fail to be Th2 suppressed. So they have persistent Th2 expression to a degree not seen in the patients who have better outcomes. But at baseline and regardless of treatment, really treatment resistant phenotypes, treatment failure is associated with a sort of overlapping set of gene modules that are pro-inflammatory in a couple of pathways and unlooked for and separately observed here, GPR15 expression and signaling. And so our hypothesis, putting these two stories together is in fact that GPR15 positive inflammatory phenotypes within the CD4 population may be important drivers of GI adverse events, and understanding that, in fact, the difference between those who actually develop EoE versus other potential gastrointestinal inflammation is a major goal. And Caitlin Burke has taken on this project, and we'll have a little bit of data to share at the Gordon conference in January if anyone's attending that. So I'll wrap up since time is short, just talking a little bit about allergic proctocolitis. So this is a disease that probably few to none of you pay any attention to. Some of the pediatric GIs will see these patients. General pediatricians see them in droves. They often never make it to the allergist's office because these are well-appearing, growing kids that have some bloody stool. They often, though, also have signs and symptoms suggestive of upper GI disease. You can fight with me about that or not. We can talk about it. They often have coincident eczema, whether that's enriched or not, or just another marker of ATP. I think probably more the latter. And many of them have disease that clinically is responsive to milk in the diet. If you challenge these patients, as is rarely done these days in the US at least, a high percentage of them, in fact, will prove to have milk-driven disease. But the natural history is benign. They outgrow this in large numbers and go on. Early work, when people did biopsies of these kids, which we never do, showed evidence for relationship to diet, presence of eosinophils in the tissue, and decreasing pathology on diet avoidance. So we had actually a couple of years ago designed an infant cohort study to better characterize food allergies, intentionally inclusive of AP, because we thought this was an interesting early onset disease that's understudied. And we found 7% in this prospective look of healthy infants that actually met our preset diagnostic criteria with grossly visible blood in the stool. Many of them, as I mentioned, also have upper GI symptoms, and they get put on reflux medications. And the primary association we found, which I'll skip through, was really to the presence of breastfeeding, which was protective, and particularly if they also were receiving some milk allergen along with that, and that's shown here. But what we've also seen, and part of our rationale for studying the disease early on, is that kids that have a history of AP in infancy have an increased risk association of being diagnosed with EoE in this retrospective case cohort study that was replicated also by Mark's group. And not only that, but they have a weaker and weaker than, say, eczema, but a statistically significant, about twofold relative risk for developing IgE-mediated food allergy. We're looking at microbiome associations, but what we think is interesting about this is sort of the unifying hypothesis of allergen-specific CD4s in across presentations, or what we might think of these days as endotypes of food allergy. And we're interested now in understanding, how are these PETH2s, specifically induced, what's their relationship to various food allergy presentations, as well as, for example, things like other EGIDs or ulcerative colitis, where GPR15 positive subsets have been implicated. What's the interaction of these with other CD4 subsets? I mentioned already that interferon signature CD4 population that I think has resonance with other data in EoE. How is GPR15 expression regulated in response to exposures such as from the microbiome and diet. There's evidence of AHR and potentially interactions with short-chain fatty acid receptors in regulating GPR15. And how do these chemotactic signals that may be driven in part by GPR15 interact with others? So with that, and apologies for not a lot of time here left, I want to acknowledge in particular Duncan in Chris's love and Bert in our group. And I've shown you a little bit of the cohort data from Tori, and I've given you a teaser to come see Dr. Burke's talk at the Gordon. Thanks.
That was fantastic talk, and definitely right up my alley of interest since I do so many dietary manipulation, and I wish I understood a little bit more what I'm doing sometime. GI, we always do the empiric diets, but there are a few questions that came through. We only have time for just very few questions. So one question that came through, basically the comment was fantastic talk, as it was, but the interest was about most patients with GI adverse events to oral immunotherapy don't develop EOE. So the question is, does the GPR15 module, is it different in the EOE versus the non-EOE adverse event group? Yeah, so you're probably familiar, I think I saw Ben Wright, was on here. So there's probably an underestimate of frank EOE as well as tissue eosinophilia in the esophagus in patients with IG-mediated food allergies at baseline, and as well as, how many of them who experience adverse events might be having increased inflammation in the proximal gut as well as in other places. But I think, to your point, I accept the point that certainly not all patients, and probably not even the majority of patients, will develop EOE. And so we hypothesize that GPR15 is working in concert with other inflammatory pathways. We do think that from, again, some data that we'll present later, that GPR15 and positive subsets may have unique inflammatory phenotypes that drive GI adverse events in other tissues in people that don't develop EOE. So we think there's going to be diversity in that population, in short. I think at this point, we're probably out of time. I'm sure several of us, including me, would like to reach out to you later with questions. Thank you so much for that fantastic talk, and I'm actually going to hand it over for closing remarks at this point. Thank you to everyone and all the speakers today. It was fantastic to be able to moderate this. I feel very honored.
Thank you very much, Kathy. So yeah, we're just going to very rapidly end this fantastic session. It's really a nice way to end 2021. So I'd like to thank all the speakers. I'd like to thank the moderator, obviously the organizing committee, and Alikos, who sponsored this particular webinar. Next slide. Just a short reminder, we're going to continue our webinars into 2022. The first webinar that is planned at the end of January is a joint webinar that will be held with the European Mast Cell and Basophil Research Network. As usual, this meeting will be held on the last Wednesday of the month from 9:30 to 11 a.m. And we already have a short lineup for the following webinars. If you want to know anything else about our program, please don't hesitate to go to our website, but you can also send an email to the address which is shown here. And we should probably very shortly be able to give more information on plans moving forward for an in-person meeting, perhaps next year. Thank you very much for joining us, and I wish to thank all of you, and to also to wish you all a happy new year for 2022.